Hello everyone. I am back, and this time is with antihypertensive medication. A quick review and a recap of all these 5 classes that we cover in adult for antihypertensives. So let's get started. So, as I was saying, there are 5 classes, and they include adrenergic inhibiting drugs. They work by inhibiting the effect of the sympathetic nervous system that increases the blood pressure. So basically, this one's just attacked or work in the sympathetic nervous system. Then you have your angiotensin converting enzyme inhibitors, or your ACE inhibitors. They prevent the conversion of angiotensin 1 to 2, and basically reduces vasoconstriction and the sodium and water retention. You have angiotensin 2 receptor blockers, or ARBs. They work in the same way, but in this case, they prevent angiotensin 2 from binding to the receptors. And it has the same effect, vasoconstriction and sodium water retention. Then we have the calcium channel blockers. These increase sodium excretion and cause vasodilation. We have vasodilators. They decrease blood pressure by relaxing the smooth muscle and reducing the vascular resistance. And you have your diuretics, which basically they promote excretion of sodium and water, and it reduces the volume of plasma, so the volume that we have in our vessels. But now let's get into each of them to really look at the medications and so on. So we have adrenergic inhibiting drugs. We have sort of 2 types or 3 types, better say, like your alphas, your betas, and your alpha betas. In general, I know the book talks like a big old list, but in general, you want to kind of know the general part. So they include clonidine and doxazosin. Here, there's not really something that they end with. These are your adrenergic alphas. What I could tell you is that clonidine and doxazosin are very common. In general, you want to make sure that you monitor blood pressure. They do lower blood pressure, so you want to do all that pre-assessment, and after the medication is given, reassess the blood pressure to see if it was effective, as well as with your beta Bs or your beta blockers, you want to monitor the pulse. They can make a person dizzy or have orthostatic hypotension, so you want to educate them on getting up slowly, sitting before they're standing, etc., and as well as making them sleepy. Specifically with your beta B, your beta blockers, they end in lol. So atenolol, labetalol, carvedilol, metoprolol. These in particular can mask diabetic hypoglycemia symptoms because they slow the heart rate down. That's why we monitor blood pressure and pulse with them. So if you have someone with hypoglycemia, they're not perhaps going to notice that tachycardia that comes with hypoglycemia. In addition, the non-selective ones, such as propranolol, are contraindicated with asthma and COPD patients because they restrict airway and cause bronchospasm. So those are the key things to know about them. Again, blood pressure and heart rate, and they can't cause or mask symptoms for diabetic patients, and are in the propranolol, especially the non-cardioselective, is contraindicated for COPD and asthma patients. Okay, then you have your angiotensin converting enzyme classification. They basically they don't allow the ACE enzyme to convert angiotensin 1 to angiotensin 2. And when you convert angiotensin 1 to angiotensin 2, what happens is that basically it it doesn't cause vasoconstriction, neither it causes the retention of sodium and water. And if you go and visit my video about hypertension, you're going to notice that sodium and water are bad for blood pressure. They increase blood pressure. So if we have a medication that doesn't allow sodium and water to be retained, then that's good. Same thing as vasoconstriction. The more that the vessel constrict, the higher the blood pressure. So if we let it relax, it works on our favor and lowers the blood pressure. These end in pril, and so lisinopril is very common. Another one is ramipril, and I think quinapril is very sort of common, but the most one that you're going to see out there is lisinopril. Now, these ACE inhibitors, you have to be careful because they have a higher risk for angioedema, especially in the African Americans. So pretty much some of the adverse effects that we want to teach is dizziness, fatigue, headaches, mood change, this dry, hacking, non-productive cough that is so annoying that makes patients stop the therapy. So this one is really, 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 really common. And because patients get so annoyed, they stop the therapy, and that's not good for them. So usually if you change the medication or stop it, the symptoms reverse. So that's something to educate them, like, hey, this could happen, and if it happens, let us know because we can, change the medication. Don't stop it without letting us know. The next class is, let me switch here, slides. Your ARBs, so your angiotensin 2 receptor blockers. So pretty much here, we're not attacking the ACE enzyme. What we're attacking is the receptors that on the angiotensin 2. So it blocks those receptors. So, but the result is the same. They don't allow vasoconstriction and they don't allow sodium and water retention. Therefore decreasing the blood pressure. These are a little bit more expensive, and in a way, if the patient has problems with the ACE inhibitors, they will prescribe an ARBs. They end in sartan. Losartan is very common. Valsartan and olmesartan is the other one, very common. Again, you want to monitor their blood pressure, but also the kidney function as well. They should be avoided with NSAID or aspirin. And some of the adverse effects are chest pain, fatigue, hypoglycemia, urinary tract infections, and weakness. They're very commonly used in heart failure, and usually they are combined with a diuretic most of the times. On your calcium channel blockers, they basically block the binding of calcium to its receptors, and it doesn't allow the muscle to contract, and also causes vasodilation. So in other words here, your smooth muscle, which is in your vessel relaxes and dilates, and so therefore it decreases the vascular resistance and therefore your blood pressure. They end in Depine. So a good way to memorize them is very nice drugs or very angel drugs. Very nice or angel drugs. The reason for that is because verapamil starts with a V, nifedipine with an and, then you have dialtisam with the D as in drugs, and amlodipine as angel as an A. So that's a kind of a way you can memorize them. You have to monitor their blood pressure, causes, of course, all of these can cause hypertension. Monitor for swelling, avoid grapefruit. In some of the adverse effects, they're the same: chest pain, fatigue, hypoglycemia, urinary tract infection. They are used not only for hypertension, I'm sorry, but dysrhythmias as well. We can use calcium channel blockers for dysrhythmias. All right, the next classification is vasodilators, and just like the word says, it dilates the vessel, so it relaxes that smooth muscle, decreases very potent medications to decrease your blood pressure. And one of the most common one is hydralazine. And let me tell you, we can give hydralazine IV, we can give PO. They're very effective in African American or stubborn hypertension. If you've tried everything and your blood pressure doesn't go up, down, and you get a little bit of hydralazine IV, usually that does the trick. Because of the vasodilation that happens in the whole body, they can experience headache and dizziness and flushing sometimes. So again, very potent. Monitor blood pressure, educate them about, getting up slowly, monitor for edema, and also they need to be avoid any kind of erectile dysfunction medication because of the vasodilation. You're kind of putting two vasodilators together. Same with hot weather or hot baths. Okay, next class is diuretics. And now within diuretics, we have like subclasses. And so, but in simple words for diuretics, they basically deal with the fluid volume. They excrete urine. So they make people pee a lot. We have sort of three: the loop diuretics, the thiazides or thiazide-like, and the potassium-sparing diuretics. On the loop diuretics, they end in mide or nide. So common ones are furosemide and bumetadine. So nide and mide. You do have to check for blood pressure, especially orthostatic hypertension. But because they make people pee a lot, we lose electrolyte through our urine. So they can lower big time potassium levels, as well as cause ototoxicity, especially if they're push IV very fast. So you want to push them slow and supplement potassium. Your thiazide, they end in thiazide, hydrochlorothiazide, and chlorothiazide. Again, another one, monitor blood pressure and potassium levels. They are contraindicated with NSAIDs. And usually diuretics are given with other medications like ARBs and ACE. So you're going to see mixtures of these medications, or combinations, better say. Then you have your potassium sparing diuretics. Here you're common one is spironolactone. They don't lower potassium, they hold on to potassium. So careful here with patients that have high potassium, and for sure like kidney issues, patients with renal issues, they're contraindicated. And also do not supplement potassium because they hold on to potassium. So think about a good way to memorize: potassium sparing diuretics, they hold on to potassium. Your loops in your thiazide, they excrete potassium. Okay, so nursing considerations in general. We want to make sure we monitor blood pressure and heart rate. We want to educate your patients on safety precautions: rise slowly, get up out of the bed, change position slowly. Is better, especially to take this medication, especially your diuretics, in the morning, so that way they're not getting up at night often trying to pee and causes a fall. You want to make sure that if the patient is on a loop or thiazide diuretic, that we give them a diet that is high in potassium, like bananas and potatoes, etc. I listed them here: potatoes, apricots, whole grain, legumes, vegetables, plums. Also, they need to know the signs and symptoms of hypokalemia in case their potassium is low. What do they experience? Well, they get leg cramps, muscle weakness, constipation, and paresthesia. Know that your beta blockers can mask your symptoms of hypoglycemia, like tachycardia. And so careful with your diabetic patients. So again, when you're looking at all these meds for hypertension, you want to know how they act, where do they act, how to recognize them, maybe with your ANS or your prefix or your suffix. And then some nursing consideration: what are you going to do before you give the drug, during the drug, and after, and kind of any education that you want to give the clients. I hope this was helpful. Again, my references are for the book and all my images from Google or the book. I'll see you in the next video. Bye-bye.